Okay, we're just at about the top of the hour right now, so let's get started. Hello, everyone. Welcome, and thank you for joining us today. My name is Cecilia Sorensen, and I'm an emergency medicine physician and the director of the Global Consortium on Climate and Health Education at Columbia University. We are so thrilled to launch the first Climate and Health Rapid Response today. As many of you know, climate change is having escalating impacts on human health around the world. As these changes and unprecedented events occur, our goal at the GCCHE is to bring together regional public health and clinical health experts to share knowledge, experience, and best practices so we can all capitalize on opportunities to strengthen health systems moving forward. So today, our panel will be discussing the recent heat wave in the Pacific Northwest and Canada from their perspective as on-the-ground clinicians and public health experts with deep experience in climate change preparedness and response. Just a few quick notes as we get started. Our goal is to really make these sessions interactive. We'll have about 30 to 40 minutes of presentation, and then the rest of the session is going to be open discussion and Q&A. So please put your questions in the chat as we go along, and we'll be sure to get to as many of them as possible. So our first speaker is Dr. Chris Ebi, who is professor in the Center for Health and the Global Environment at University of Washington. She has been conducting research and practice on the health risks of climate variability and change for nearly 25 years, focusing on understanding sources of vulnerability, estimating current impacts and future health risks, designing systems for improving resilience, and she is the author on multiple national and international assessments on climate change and health. So thank you so much for joining us today, Chris.
Thank you, and thanks to everybody who's joined for your interest. It's great to see some familiar names and people that I look forward to interacting with as we go forward. Whenever one talks these days about heat waves, one does so in the context of climate change. This is a very nice graphic someone put together on the Working Group 1, which is on the physical science basis report from the Intergovernmental Panel on Climate Change 6th Assessment Report. And you can see that the report was quite comprehensive, covered a range of issues from the current state of the climate to projections with different levels of warming going into the future. An important issue, particularly for our discussion today, are the projections of how heat extremes could change over the next several of decades. To understand this chart, the climatologist looked at the period 1850 to 1900 and determined the one hottest day on the left, or on the right, the one hottest day in 50 years. Looked at how often that occurred during 1850 to 1900, obviously occurred once. Looked at, it says present day we're actually at 1.2 degrees C above pre-industrial, so we're past the present, moving into the 1.5. But you can see today that the 10-year event occurs about 3 times as often. And you can see that the 1 in 50-year event is almost 5 times as often. And you can see what the consequences of additional warming could be. So significant increase for heat extremes. And this includes the frequency, the intensity, and the duration. Within that context, there was a heat wave that we're talking about today in the Pacific Northwest and in Canada. There was a rapid detection and attribution study published on this within about a week of the event. There were several things that were quite remarkable. One was how extreme the extreme was. That no one until that time had seen temperature records broken by more than 10 degrees Fahrenheit, about 5 degrees Celsius. And so the records were very extreme. Certainly the region was not prepared, and we're going to hear a lot more about that. The death certificates are still coming in. The latest numbers I saw for Canada, around 650 excess deaths, perhaps higher than that. For the state of Washington, I think it's about 500 excess deaths, maybe 200 excess deaths in Oregon. When we're thinking about these kinds of events, that event was unusual in many dimensions, But the detection attribution study concluded that that heat wave was virtually impossible without climate change. And put this into context of a recent study that came out looking at the proportion of heat-related mortality that's attributable to climate change. And overall, looking around the world, about 35% or more of all heat-related deaths over the last couple of decades are attributable to human-caused climate change. It, of course, is not just the heat. All of those in the Pacific Northwest are deeply concerned about the wildfire risk. You can see as temperatures go up, there's more acres burned in the Western states. There is a very large amount of literature showing that exposure to wildfire smoke is associated with a range of chronic diseases. I also want to point out, you see the air quality index at the bottom. It's based on PM 2.5. Yesterday, the LA Times reported an air quality index of one of the communities around LA of 760. When we think about what it is we need to do, we need to put heat and wildfires into the context that they're an all of society problem. I'll talk a little bit about the health impacts of heat, but we know that it's not just human health. It's also, in our region, we saw impacts on agriculture, on livelihoods, deep concern about outdoor workers. People at higher risk included people in elderly care facilities, people who play sports. And so when you start thinking about what it is you need to do, you need to think about how to approach it from an all of society perspective. I think I'm missing a slide in here. I wonder where it went to. Anyway, you can see here's a graphic I took from Public Health England. There's a problem with this. Sorry, this is not my latest slide deck. So I will use as an example a heat wave plan for England that has been in place for quite a number of years. You can see the core elements there. And putting in place heat action plans are frankly not very expensive. They're a large organizational activity. I'll go back to this slide. My computer will let me do it. So this is an example for the plan for England, showing the different kinds of partners that are engaged. When one develops the heat action plan, you need to think about all the different agencies, institutions, and other partners with whom to engage to make sure that not only do you develop a plan that is useful and usable, but you've got mechanisms for the outreach to particularly vulnerable communities. And there's lots of opportunities to further expand on the kinds of services that are shown on this slide of reaching out to, for example, our faith-based organizations, because they have very strong outreach into particular communities. Looking at people who work with the red line districts that we have, for example, in Seattle, and how to reach most effectively out to them. You want to do that. They've got fewer trees by and large, and so tend to be hotter than the urban core. This particular heat action plan has multiple levels, but when you decide the levels, when you decide exactly how you're doing the outreach, you have to take into account the local context. You have to understand the particular location and what's the most effective way to reach out to them. And this is just a summary for commissioners of health and social care professionals on what they do in the UK in this heat action plan. I'm not going to go through this, but it gives an example of thinking about how to work at the various levels with various organizations throughout to make sure that whatever messaging you develop is going to be useful, usable, and effectively taken up. Thank you, and I look forward to the next set of presentations.
Thank you so much, Dr. Ebi. I'd like to next introduce Dr. Jeremy Hess, who is Professor of Environmental and Occupational Health Sciences, Global Health and Emergency Medicine at the University of Washington. He also serves as the director of the UW Center for Health and the Global Environment. Dr. Hess is a lead author on several national and international climate assessments, including the IPCC special report on managing the risks of extreme events and disasters to advance climate change adaptation, as well as the 6th assessment report. He's also an author on the annual Lancet Countdown on Health and Climate Change, and is a consultant for the Centers for Disease Control program on climate and health. And he is joined today by several of his clinical colleagues in the Washington area. So I'll turn it over to you, Jeremy, and thank you so much.
Gotta unmute. Thanks, CC. As CC noted, we've got a little panel within a panel today. So I'm going to kick us off by doing a quick report out in SBAR format, which a lot of you will be familiar with as a way to quickly update colleagues about a concerning situation. And we're part of an outstanding team here that spans different professions and different generations. And we all did our best to step up to the plate during this event, but it was pretty stressful and difficult. And I'm really proud to share the stage today with my colleagues and outline their stories, because that's what really matters in events like this. So kicking us off, starting out with the situation, as Chris noted, this was a historically unprecedented extreme heat event with a really large geographic reach. And we also had relatively short advance warning. The warnings started to come about 5 days before the event, which was enough for us to do some things to prepare, but particularly in a region that isn't used to this sort of event, it was not a lot of time to mobilize and kind of shake us out of our comfort zone in anticipation of what was truly a record-breaking event. The context here is also that we were already really straining or struggling with capacity issues, and that mostly had to do with COVID. The images here come from the Harvard Global Health Institute and were compiled by ProPublica, and they show the proportion of beds that would have to be emptied from a region's healthcare systems in order to accommodate new patients. And as you can see, with an increase of 20% over 18 months, the Pacific Northwest would already be strained, as would much of the Western United States, in fact. But if you increase the demand for beds over 6 months, we run out of beds. And that's essentially the situation that we found ourselves in before this event occurred. We also found ourselves in a situation where we have a lot of underlying chronic vulnerability. And a lot of our patients, particularly the most vulnerable, don't have outstanding healthcare access. We have better healthcare access than many other parts of the United States, but still many of our most vulnerable community members struggle to get the care that they need. So in terms of the background for the specific event, of course, we are in a historically cool climate, and our housing is generally built for heat retention, not for shedding heat. We have relatively low AC prevalence, and you can see that here. It's gone up since this graphic, which was produced in 2015. It's about 44% now in Metro Seattle. But the differences and the equity concerns persist. So low-income households are least likely to have air conditioning. And while older individuals are more likely to have air conditioning than younger individuals, the prevalence among elders is still pretty low. We also have very little lived experience with extreme heat here, either as a health system or just in the general population. And so we don't have great reflexes when it comes to protecting ourselves from extreme heat and advancing health system awareness. And then our population has grown really rapidly, and our health system hasn't really kept pace. And so these are two images that show essentially strain on physicians and nurses in terms of capacity, that we don't have any slack in the system. And that was going into this event. We really are struggling with that over the long term. And COVID has made it that much worse. So given all of that, our assessment right before the event was that despite efforts on the part of the public health authorities and healthcare organizations, we would have some challenges with risk communication and our public health response. we expected to see a lot of people, particularly vulnerable people, coming into the ED and being admitted to the hospital. We expected a dramatic uptick in heat illnesses coming to the ED and a large absolute increase in chronic disease visits to our healthcare facilities. And we expected that our staffing issues would hinder our ability to respond. And that's exactly what we got. This was the deadliest weather-related event in Washington's history. In the 4-state region, there were an excess 3,500 visits during this time. It was a 100-fold increase in heat-related ED visits just on the 28th of June alone. And rapid analysis by colleagues at CDC in the bottom left there shows that huge spike in ED visits. And then on the right, the New York Times recently did an analysis showing number of excess deaths. And as Chris noted, we're still counting. So we don't have any more formal estimates than that from our public health authorities, but we expect the counts to increase as we go forward. But as they say, numbers numb and stories stick. And so I want to hand over to my colleagues. We've got 5 today who are going to tell the story from different perspectives. I'll ask each of them to introduce themselves and say a bit about their role during the event and tell their story. So I'll stop sharing and pass it on. Thanks.
Hi, good afternoon, or I guess actually I think evening for some of you. My name's Amy Lee. I was lucky enough to be the charge nurse that night in the emergency room. So I'm just kind of here to kind of set the scene and let you know what it was like. I think a lot of you probably work in emergency or at the very least healthcare. So you're aware that staffing issues are probably an issue across the country. I also want to let you know our biggest, for anyone who doesn't work in emergency, Mondays are always some of the worst days in emergency. So it's always just a busy day. This, as I believe everyone has already mentioned, was our warmest day in Seattle history, was June 28th. And that followed the second warmest day in history, which followed, I don't know where Saturday was on the scale, but it was pretty high up there. So we kind of had a compounded effect of 3 days of extreme temperatures, adding to a lot more patients than already our normal Monday problems. So with a lot of staffing and a lot of patients coming in expected, we were kind of set and ready to go. And then Dr. Mitchell, who's going to speak a little bit later, kind of let us know about some other areas in the other issues in the area, sorry. One of which was we had some hospitals that had equipment issues, shortages of different pieces of equipment. Another hospital lost power, including their air conditioning. Another hospital lost their lab and their ability to process tests. So what that kind of translated to us is that we had to get ready to expect a few more patients. So this led to some creative solutions. We started putting 3 vented patients in a room designed for 2 and things like that. We have really great teamwork at the hospital. Everyone from our CEO down stepped in to help. Our local ambulance service actually stationed one of their supervisors with us to kind of help facilitate moving people around. One of the sad things was actually a lot of patients we did expect, we were ready for, never actually made it to us. A few times we were standing around waiting, and then we would get the call back that they had expired prior to arrival. I remember specifically speaking with one paramedic, and I asked him how bad it was out there. He showed me where he had little burns on his knees from being on the ground intubating. And he said he was intubating about 3 times an hour and had been for a few hours at that point, transferring to whatever hospital had availability. So it really, really did hit home. I think actually Dr. Gans is going to speak specifically about some of the patients that we saw that day. So I'll let Ellie take over.
Hi, I'm Ellie. I'm one of the third-year residents at University of Washington, and I worked the whole weekend during the heat wave, but specifically Monday night, I was the senior resident at Harborview Medical Center. And during that role, we actually answer the radios in direct medical control before we activated our DMCC, or disaster response. And so just to kind of reiterate and emphasize what Amy said, the sheer volume of calls we were receiving from our medics was quite surprising and nothing I had ever experienced before in my vast 3 years of residency. But I really think what was important in that experience, and what I later reflected on when I was seeing patients clinically in the emergency department, was that the story was always the same. The medics would call and it would be an elderly person, an unhoused person, a person who didn't speak English, who was found confused incredibly hot to the touch. And because they were confused, they were deemed unable to protect their own airway. And so they were intubated and needing emergent ALS transport to the nearest facility. Each time I saw a patient and I spoke with their family, it really just hit home that these deaths were preventable. All the family members said, I checked on them earlier in the day and they were doing fine. It was a little hot in the house. And then hours later, I checked back and their status had clinically deteriorated. Obviously, those weren't their words, but they were on the ground unconscious. And in that, I think the whole experience demonstrated to me how important teamwork was in the emergency department, activated the DMCC, which Dr. Mitchell will talk about, but also just demonstrating the horrible effects of climate change on health to the front lines. And I think my colleague Lucy was kind enough to take over the radios for me so I could provide patient care, and she can tell you a little bit more about her experience with patients that day as well.
That's the handoff to me. So my name's Lucy. I'm one of the other third-year EM residents, and I had worked the day shift before Ellie came on, and I had seen my share of heat stroke patients, and it really was a gradual progression, starting with an elderly patient in an apartment with her elderly husband who had called 911 because she was sleepy and he had a hard time waking her up. She came in, her temperature was 103, and our way of managing these patients, we don't have cooling fluids in our ER, at least we didn't at that time. And so we would lay out a body bag and put the patient in the bag and then put bags of ice around them in their armpits and their groin and just keep monitoring their temperatures. And obviously there are more invasive ways that we could have controlled their temperature, but for a lot of my patients that morning, that was our approach. And so we would anticipate someone coming in if they had a high temperature or the medics reported it was hot in their apartment. We just lay out a body bag on the cot before they arrived just to have it ready, which was morbid but effective. And then towards the evening, as I'm wrapping up my notes, there's this shift in the temperature, so to speak, of the department where medics are arriving more frequently. I'm hearing the medic one call, the pager go off more and more often. And it just seemed like it was escalating very quickly, as I think what happened was people were hoping that as night fell, the heat would break and apartments would start getting cooler, and they didn't. Instead, heat was just accumulating all day long. And these people in second story, third story apartments without air conditioning were finding the heat rise and rise, and they weren't able to control it anymore. And so at that point, I stayed to find out how I could help with everyone as the disaster system was getting activated. And so I took over the role of just handling the pagers, because normally that is part of our clinical duty as well, so that Ellie could focus on patients. And I was getting, when I walked in at first, both the attending and Dr. Gans were handling phone calls back to back for probably 15 minutes without being able to leave the radio room, just constantly answering medic calls about intubated sick patients. And when I took over, at one point, within about an hour and a half, I got 3 calls of CPR on elderly patients that we ended up calling over the phone. And I think at that point, I realized we were not dealing with, this was not heat. I had always just thought about heat as a environmental thing that could be sort of addressed, but every medical condition was being exacerbated. Every patient who was on a beta blocker who was dehydrated was incredibly sick. People who maybe would have normally been fine found their medications that they were taking appropriately were now acting against them. And then when the patients did arrive, whether they were intubated or not, and Dr. Mitchell can talk about the limitations on our ventilators and the stress on the whole system, even if we got them cool, we couldn't send them home. What were you going to do? Send someone who was unhoused back to a street that was 105 degrees, send them back to an apartment that was 115 degrees? But we can't keep them in our hospital either, because we're out of beds, we're out of nurses. We have a nursing shortage. We haven't had beds available for a long time. And honestly, the department was already feeling warm just for me walking around, we were already starting to all glisten. Medics were coming in sweating. There was just not a whole lot besides our poor ice machine that did overtime that day to try to support people. But you would just have people in the hallways because we just couldn't send them back to the same apartment and have this happen again. So I will pass it to the rest of our team who was more involved in terms of coordinating the whole area of hospitals. But this was something that really impressed on me how fragile and what a limitation we have on our available resources. I think as healthcare providers, we want to always give and be able to stretch and take on when people are sick. But between the heat wave, other medical conditions, it's summertime, traumas were also happening. You know, there's a limit, and unfortunately, we were right at that limit in terms of what I was witnessing us being able to handle.
Cameron, you want to tell us about Valley?
Yeah, thank you, Lucy and Ellie. My name is Cameron Buck, and I'm the Emergency Department Director at Valley Medical Center, which is a community hospital in the UW system, about 20 miles south of the city, and essentially very, very equidistant with SeaTac Airport. And my framework as the medical director is we knew within some time period, as Jeremy said, within 5 days that we were going to have a heat-related event. And so we did some preparations as it relates to educating our teams, understanding our capacity, but I don't think we really understood the impact of the scope that we were going to see. And I'll just give you some reference numbers. I worked that day a swing shift on Monday. Over the 3 days that we would describe this heat-related event, we had about a 13 to 15% increase in our volume, which might not seem like a lot, but they were certainly a higher acuity patient. We saw about 95 to 100 heat-related illness over that 3 days in the ED. And I want to hone in on the June 28th, because I think that puts some perspective on things. So in an 8-hour period of time on June 28th, which I would describe as the peak of this event, we saw a heat-related illness coming in by EMS 1 every 9 minutes. So about 6.5 to 7 an hour. So in that 8-hour period of time, we saw 53 to 54 patients, depending on how you counted. And so that was the majority coming in a very, what I would say, compressed time. And that put a lot of stress on our system and something we weren't prepared for. Of those that came in that 8-hour period of time, 15 were intubated. 15 were intubated. And so while we thought we were somewhat prepared, while we kind of defaulted to our ER nature of being flexible and team-oriented, and we certainly relied on good communication, incident command, that 8-hour period of time really completely overwhelmed the community hospital. For example, we have 30 ICU beds, and it typically was already running at a 90 to 95% capacity. So in that 8-hour period of time, we became very significantly overwhelmed. The population that we saw is somewhat, has already been referenced. Patients that were elderly, the average age of our heat-related illness patient was 73 years old. Most of them came from congregate or adult family homes. The highest temperature we recorded was 108.6. And the highest temperature that I was aware of that was recorded in an environment by EMS with their detection devices was 122 degrees. And so I guess those numbers are kind of striking to me, and the patient population and the types of patients we saw were exactly as Lucy and Ellie defined. We thought we kind of defaulted to more our event medicine kind of manner as we cooled lots of patients that were maybe exertional heat illness. We found it very challenging to cool non-exertional heat illnesses in patients that were hypotensive, ventilated, and came in a high number of surge. So while we had ice, we might have had some high-tech things with surface cooling units. That short period of time in surge essentially overwhelmed us from a resource standpoint. So with that, I'll turn it over to Steve.
Good afternoon, everybody. Steve Mitchell. I'm also an emergency physician and the medical director of the emergency department at Harborview in Seattle, the location that several of us have referenced this evening. And I want to approach this from more of the regional view. Harborview has served for decades as what we refer to as the Disaster Medical Coordination Center. And so it's typically stood up in large scale single event disasters like, large crashes or in our situation, an earthquake or a mass shooting, those types of issues. And the goal is to then distribute patients in a way that affords people the greatest opportunity of survival and to try and level load the health system in the midst of that. And in this situation, we eventually applied this, but as others have mentioned, it was anticipated, but none of us, including myself, had a frame of reference for what it could be. All of that has now changed. And I too, like several others, have been working that day along with Dr. Godson. And as we were leaving that day, having seen several patients, knowing this was busy, knowing there was a significant overlay of everything that had been going on, fortunately, it was near one of our naders for COVID illness in our hospitals. I just shudder to think what it would be like today. We are still in August, but in the afternoon of this third day, things had indeed been escalating, and we began to receive regionally reports of, we're worried about this hospital. This hospital may need to evacuate because they're on generator power. They may lose all of their power. We had several reports of skilled nursing facilities in the same situation where they were losing power throughout the entire region. And as we went along, though, I was really, what we don't do well yet is have an understanding of the EMS distribution of patients, where their calls are located, and where they are sending their patients to. And what I didn't appreciate was how this illness could affect certain populations that are concentrated into sub-geographic areas within our larger community. And so I had been operating under the assumption that, yes, everybody is having a rough time, everybody is having difficulties, meaning all of the emergency departments across our region. And we knew we started from a very challenging place, but that everybody was probably in roughly the same situation. However, late in the early evening, I got a text message from Dr. Buck, which I have saved on my phone, which is, and all he said was, "We are in crisis." And amidst the chaos and some other messages, we eventually reached out to and had a few quick conversations and realized this was completely different. And what we did in response was we immediately got all of the hospitals together for a quick conversation, status reports on everybody, and we realized that all of us were in bad shape. Several of us were in severe condition, but then Dr. Buck's hospital, Valley Medical Center, was in true crisis. And so we then stood up an operation to control EMS traffic throughout the region not for everything, we couldn't do that, but for severe heat-related illness with our paramedics. And so hopefully that led to some alleviation. We certainly were able to direct people or direct patients away from Valley Medical Center, because one of the myriad reports that we'd received that have been alluded to was that Valley Medical Center was down to one ventilator, and I knew that patients were continuing to come who had severe illness to his hospital, and so we were actually working on loading ventilators into an ambulance and sending them down to him when we had some workarounds developed where we did not need to. And so We have certainly changed our approach as a region to heat-related illnesses. As a result, we have a completely new frame of reference, and it has taught us some invaluable but painful lessons in the process of doing that. Thank you.
All right, well, I want to thank all of my colleagues for their hard work. Cece?
Yeah, thank you so much, everyone. Thank you for sharing your stories. I have chills right now as an ER doctor. I've actually never been in that type of situation quite like that, but I feel it right there with you. And it sounds very, very sad, honestly, and scary. I think these things can be prevented, and I think that's why we're here today. So with that, I'd like to introduce Louise Aubin. She is currently the Director for the Health Protection Division of Peel Public Health. Her current responsibilities include climate change, air quality, food and water safety programs, enteric disease management, public health hazards investigation, the prevention and management of vector-borne diseases, and tobacco control programs. She has been heavily involved in Peel's COVID-19 response, as well as in the design and implementation of their heat plan. So I'm very happy to have you here today, Louise, to tell us a bit about what you've been doing in your region to prepare for severe heat events. Thank you.
So thank you, Cecilia. I'm just having a little bit of problems getting my screen up. So can you tell me as soon as you can see it?
Absolutely.
Can you see it at this point?
Not yet. Let me see.
Okay.
I have your slides as well.
Okay, if you could load them, that would be great.
Absolutely.
So while they're getting loaded, I'll start, and if you could tell me when they're up, that would be great. So first of all, those were some really powerful stories to hear, and the purpose of the work that we do is to ideally prevent those kinds of situations from happening. So I'm going to tell you a little bit about our story, and I do want to acknowledge one of my colleagues who worked with me on this is in the audience. So a shout out to Helen Doyle for her assistance as well. So if we could go to the next slide. So for those of you who aren't familiar with the region of Peel, I thought I'd start with just setting some context and some background. We are part of the province of Ontario, and so not part of Western Canada. If you've ever flown into Toronto, you have been in the region of Peel because the Toronto Pearson Airport is in our jurisdiction. Ontario is a vast province, and just to give you some context, the southern tip of Ontario is on the same latitude as Northern California. And so as a result of the vast geographical size of the province, the climate is very different in different parts. And that's a challenge for developing a meaningful heat warning system. So just if you could go to the next slide. So the region of Peel is immediately west of Toronto, and it's an upper tier municipality made up of 3 municipalities, Mississauga, Brampton, and Caledon. It's an urban-rural mix. The southern part of the region is highly urbanized, and the northern part in the town of Caledon is still very much rural. The population is about 1.5 million. It's growing rapidly. Pre-COVID, we were adding about 30,000 new residents per year. And many of those residents are newcomers to Canada. They don't necessarily speak English. They're not used to the Canadian system. And the region of Peel is a series of pockets of villages which sprawl has infilled and connected. Much of the housing stock is relatively new, 1980s and later. And for the region of Peel, Peel Public Health is one of 34 health units that exist in Ontario. The region of Peel also provides paramedic services for the hospitals, and our work is guided by the Ontario Public Health Standards, which I'll speak to in a second. So if we could go to the next slide. So what I'll be talking about today is both our experience and the Ontario level experience because they're very intertwined. We created a heat warning system for the province, and I'll talk a little bit about what that experience was like, what the learnings were, and what we're going forward with in the future. So next slide. So pre-2015, there was no commonly used method by Ontario health units to trigger heat warnings. Some of the jurisdictions were using a synoptic weather system. Others were using humidex. Some were using temperature and accommodation of humidex, and others were throwing air quality into the mix. And so it was quite possible for one jurisdiction, based on their criteria, to issue a heat warning where the neighboring jurisdiction would not, or the warnings would be different. And people moving around in the Golden Horseshoe, for example, the area surrounding Lake Ontario, it would get really confusing in terms of what was what. For Peel Region, in 2011, 2012, we conducted a vulnerability assessment for climate change using a public health lens, and heat was identified as a key area of vulnerability. Once we did that assessment, we looked at our capacities and programming and concluded that we needed to look more closely at heat. We were running a heat alert system at that time, but it wasn't as robust as we were comfortable with. So we organized a day-long heat session with our many stakeholders, including hospitals, shelters, first responders, school boards, community care providers, and so on, and did a day-long exercise which included a heat emergency. And in that process, we found several areas of concern: communications to vulnerable individuals, gaps in vulnerable populations being served, issues with highly vulnerable patients who would be shuttled between community care and hospitals, and it would just create a spiral. So that led to a discussion with our neighboring health units, and there was consensus that we all needed to come together. We did reach out to Health Canada, who we had already been working with on an air quality health index, and other relevant parties. So working together with the Ontario Ministry of Health and Long-Term Care, Public Health Ontario, which is our scientific arm that provides EPI and other surveillance supports to public health units, Health Canada, federal agency, Environment and Climate Change Canada, which is also at the federal level, and local health units, the Ontario Public Health Association. We came together to create a heat warning system for Ontario, and Secretariat services were provided by one of our local environmental agencies called the Clean Air Partnership. Next slide. So the goal of the heat warning system, the focus of the work was on developing an efficient, coordinated, evidence-based system with standardized criteria for issuing heat warnings. This was really actually quite challenging because many of the health units, as I had already indicated, already had systems. They had established processes, they had relationships with their local stakeholders, and they had invested money in communications material. So it really was a concerted effort, and people coming together with a common goal to work this through. There were a series of subcommittees that were set up to review the science and EPI data, to develop appropriate triggers, and to develop appropriate communication tools. So the next slide. So the outcome of this was the standard operating practice document called a Harmonized Heat Warning and Information System for Ontario. And so it lays out all of the triggers, the protocols for heat warnings in Ontario. The forecasts are provided to us from Environment and Climate Change Canada. Sorry, I've got to get that name straight. And early notifications are sent to local stakeholders by the public health unit. Fortunately, as we were developing it, the Toronto area hosted the 2015 Pan American and Parapan Games. And so this gave us an opportunity to pilot test and to harmonize the response system. So next slide. So each health unit in Ontario calls the heat warning based on the same process, but the response to that heat warning is location specific. Each health unit is different, serves different mixes of urban and rural, different populations. And so the local response is tailored to each jurisdiction. The document breaks the province down into a number of regions, and the triggers for the heat warning process are based on the region, the intensity, the temperature and humidex, looking at both day and night temperatures, and the duration, the number of days of the heat event. So the process starts based on forecasts from Environment Canada. As a heat event approaches, they push a warning to designated staff. This triggers action on behalf of the health unit and then local stakeholders. At the beginning of the season, for the first heat warning, Environment Canada releases a special weather statement. This is done in recognition that heat is riskier earlier in the season before people have had time to acclimatize to the weather. So there are 3 parts to it: an early notification system. So public health units activate notifications to key partners in advance. This allows for the stakeholders to ramp up. So for example, if they're running extended pool hours, they can staff, they can do whatever they need to do. For the region of Peel, that's a distribution list of approximately 300 people. And these are all organizations. This is not to the general public, it's just to agencies. The second step is the heat warning. And so the public health unit will notify key partners and activate communications activities to the public, media, social media, et cetera. Provides information to the public about risks and health protective measures. And then for many of the public health units, it also triggers real-time surveillance of data coming in from the local hospitals so that we can see if there's an increase in emergency room visits, if there's an increase in admissions, et cetera. If the heat warning goes on for an extended period of time, beyond 2 days, within the context of the local plans, the public health units will communicate the extended heat warning, and that allows the stakeholders to activate the next stage of their plan. Next slide. So just to break down the roles, the heat warnings are provided by Environment and Climate Change Canada. The local public health unit receives the heat warnings. They communicate information based on these warnings. The public health unit will work with the local partnerships around planning activities. They'll share information with their local partners. They conduct surveillance of the local heat impacts and participate in the evaluation activities. Next slide, please. The local municipality will fan out based on their network, the heat warning. They support public communications of the heat warnings. In many cases, but not all, they'll make cooling spaces and hydration available to the public. I've mentioned, for example, extended pool hours. They'll work to address the needs of vulnerable populations. Next slide. Again, the local area municipality will work with the paramedics, the first responders, long-term care facilities. They'll also work on issues with respect to critical infrastructure, occupational health and safety, and in the event that things go into a full emergency, activation of local emergency operations centers as per existing protocols. Next slide. I did speak about the Ontario Public Health Standards. Now, this document provides the activities that the public health units are required to provide. And so in the development of the heat warning system, we work to have this embedded in the public health standards so that it would be standardized across all the health units in Ontario. And so there's language in that document, which I'm not going to go through, that ensures that there's consistency across the board. Next slide. So in thinking about changes that we should be thinking about preparing for the future, right over the last little bit, we've been working hard to incorporate COVID-19 guidance into existing heat strategies. If you're running a cooling center, for example, how do you ensure that it's protective of the people who are there with respect to COVID? We've been working with various stakeholders to address the impacts of local climate change. And for heat-specific examples, previously there were no maximum heat bylaws. And so in Ontario, it gets quite cold. And there were bylaws that required the heat to be on in buildings up until a certain date in April, and we were getting heat warnings where it was 30, 31 degrees, or in the 80s, high 80s, for those of you who are in the States, and the heat would be on in the apartment building. So in order to prevent those kinds of situations, we've worked on heat bylaws. We do a lot of work on built form, making sure that the infrastructure, both hard and soft, is reflective of concerns around heat. Tree planting, making sure that looking at permeable pavement, looking at shading, all those kinds of issues. The region of Peel is a highly diverse community. Most of the population has arrived in Canada in 1980 and on. And so making sure that our heat warnings and our programming, our communications are socially and culturally appropriate. We're finding that a large part of our population comes from Southeast Asia, where a hot day in Canada is a normal day where they've come from. But over time, their bodies acclimatize to the Canadian culture. And so making sure that we're working with those communities, that the messaging, that everything that we're doing is culturally appropriate. Also, the graph in the slide shows some of our epi work. We published a study in 2019 that looked at heat specifically, and I've got another slide in a second, but we can clearly see that the mean annual temperature in Peel is increasing. So tracking the data to make sure that we are responding as quickly as we can to various things. Next slide.
Okay, 1 minute left.
Thank you. I'm almost done. With respect to data, I mentioned already gathering the epi data and also mapping. It's a really powerful tool in terms of identifying vulnerable populations and making sure that we understand the neighborhood characteristics. Next slide. I did talk about the epi data. So we've been tracking extreme weather related emergency room visits, looking at heat for the Canadian context, looking at cold as well, other extreme weather causes. And you can see over time that there is the beginning of a trend happening. So just making sure that we're tracking that data. And then Cecilia, the next slides are just resource slides that I've put together that people may want to access, Region of Peel, Ontario ones, and then to flag some new ones that are coming out from Health Canada. So with that ends my presentation, and thank you very much.
Thank you so much, Louise. And we will post these resources on the website under the event section on the GCCHE. So if you don't have time to jot these down, we'll have these posted and available for you. Thank you everyone for these incredible presentations. Stefan Wheat, our Climate Health Science Policy Fellow, is going to start with our Q&A. So go ahead, Stefan, if you want to let us know some of the questions from the chat.
Yeah, well, again, thank you for everyone who is here, both participating and giving speeches here today. I think, there have been a lot of really interesting questions. I think I really appreciate, Louise, you addressed a lot of the questions that were looking at some of the systemic adaptation efforts to heat stress. But I think, since we're relatively short on time, what I'd like to focus on is, what are the lessons learned from this recent event here at the end of June? What can we take away from this and say, what can we make better? How can health systems be better in the future? And open to any of our panelists.
If you'd like, I said I apologize, my computer's just not syncing very well. I can show one of the infographics while people are talking from the Lancet series that was published last week. Let me just show this one, if you don't mind, because clearly we need to have heat action plans. This is one of the infographics on sustainable ways to stay cool. there's another large table that shows a whole range of options that are possible to think about in terms of, you heard about planting trees and other options. And with that, I'd be very happy to turn it over to others. Just thought I'd give people a chance to take a look at this.
Thanks, Chris. That's really helpful. One of the things that I wanted to emphasize about lessons we learned is that the changes that climate change is increasing the probability of can happen really abruptly and affect regions that are patently unprepared for these changes. And moreover, the changes interact with other stresses that are already underway. They may or may not be climate driven. And in this case, some of them aren't, some of them were, some of them weren't, a lot of them weren't. But we can learn from patterns related to other stressors. And one of the things Steve had to drop off, but one of the things he wanted me to emphasize was that the patterns we saw during this event were very similar to patterns we saw with the emergence of the North American COVID outbreak, that certain communities were highly impacted and it overwhelmed local capacity and created a disaster locally for those facilities. And that was the same case for us, particularly at Valley, and we were able to recognize that and respond, and I think it made a difference, but it still was a harrowing experience, and that's pretty prototypical. And some of the work that Chris has done on stress testing health systems is actually quite relevant here, because I think we're seeing a lot of patterns as we went through what was clearly a stress test for our system and our community.
And Jimmy, I'd like to add to that a point you've made quite a lot, is what happened in the Pacific Northwest is just classic of what's happened in heat waves in other places. There was heat waves in 2003 in Europe. There were 70,000 excess deaths. The following year, there was a heat wave in the Netherlands, and the Netherlands did not have a heat wave early warning response system ready to deploy when that happened. And there was over 1,000 deaths just in the Netherlands. And we all need to start developing heat action plans. Just because we haven't seen it, it just means it's going to be some time. It could be next week before we do, but we are going to see it.
Thanks so much, Chris. You know, I think one of the other issues that I'm hoping we can talk a little bit about is the compounding, or, you know, the syndemics that occur. There was the heat wave, and then very shortly after, there were wildfires in the region. And, you know, I think it's one thing to sort of have a heat action plan, but is there a role here for a multi-hazard action plan? And how do we iterate plans such that we're able to sort of have an all hazards approach? Because, you know, I think as what happened in the region, nobody was expecting this type of heat wave, right? And that kind of puts us on this guard where, you know, anything could happen anywhere potentially, right? So is there a role here for sort of an all hazards approach, and potentially what would that look like?
Exactly, CC. One of the big challenges we have here, as Jeremy very clearly noted, is low access to air conditioning. And we also have a lot of wildfires. And so I gave the statistic for a place outside of LA 2 years ago around my house. The air quality index during a wildfire was about 250, somewhere between 250 and 300. I'm very fortunate that I have air conditioning, but what do you tell people when it's really, really hot? And your air quality index is 300. Someplace in Nevada yesterday was 400. And how do you start handling these multi-hazards and setting up early warning systems so that you can respond to these compound events?
Thanks, Dr. Ebi. And this last question is to our clinical consultants for the day. What advice do you have both to patients as well as to other health providers in this era? And it sounds like, you know, your experience was incredible. And I'm wondering how you can advise others who could be faced with a similar situation, and how you would advise patients to prepare for things like this.
I can start. What I wish I had done I had started working on Friday of that weekend, and I had thought about kind of meeting with social work and getting a paperwork packet for every single patient I saw that day throughout the weekend, whenever I discharged them, and giving them, just like that infographic we just saw from Dr. Evie, that was fantastic, and giving them resources so that they could read it over the weekend, and really giving them kind of strict return precautions like all emergency medicine doctors do, to go seek some sort of cooling system when they start experiencing heat. I think that is a very easy step, and a step that I hope to take the next time this happens, if it's in the next week or next summer.
Yeah, Cameron here. I couldn't agree more. I mean, I think emergency medicine sees ourselves as as a platform or the porch of the House of Medicine and healthcare, and preventative medicine is part of that. I think in the moment when we were at our peak on June 28th, certainly could have prevented at least half of those, if not the majority of those heat-related illness presentations. And so preventative stuff is something that we need to entertain. So that's obvious lesson number one, proactive plans. For me, this was a great, I won't call it an exercise, but a great example of a relative mass casual incident. So it really was great on communication. And I think we could have defaulted more to simple when it relates to cooling. We thought we had a plan as it relates to cooling patients, but when the numbers exceeded our capacity and there was some relative chaos, we overcooled people. We didn't quite have the resource that we wanted. So I think what we've learned from this is we created a cooling plan so that all of our healthcare workers, all of our team members understand how to cool people efficiently and when to stop cooling them and have an exit plan, and then how to deal with some of the complications. From our MST staff to our nursing, to our respiratory care therapy, to our intensivists, and to our social workers and support teams. That's something that we learned in the moment, obviously, and then applied those lessons afterwards.
I think something I learned from Dr. Hess afterward when I was debriefing that shift too in his work on heat in the past was not to underestimate how hot it is inside a building versus outside. And that temperatures inside a building can be anywhere from 10 to 20 degrees hotter than outside. And so I think that was certainly something I learned. For patients, I think Ellie's idea is awesome. I think there were patients who just didn't, like they would come and be like, my wife, she seems tired, and her temperature is off the chart. And just recognizing those signs and when to be concerned, I think, so that people anticipating, and if you can anticipate a weather event, have that in their arsenal. And what I can't give everybody, but I wish I could, was just the social support to have an option, trying to call up a family member to say, do you have air conditioning? Can you take care of your mom tonight? Was what was the best, discharge for some of our patients. And had we been able to anticipate that, which I've since found some patients reflect, like, oh, it's going to be hot and I'm going to stay with my daughter or my son. But that was really kind of the best case scenario, was that someone would have a family member or a friend with air conditioning to go to. And then one other thing that's come up too is I think a lot of our protocols and a lot of the ways that we manage patients, for EMS as well, when they see someone who's obtunded and hot, is to intubate. And that left us, with a lot of phone calls about intubated patients that were really sick. And this is kind of beyond my expertise, and I don't know what they see in the field, but I wondered how many of those patients we could approach in a nuanced way, as we knew that resources were limited. Like, do we need to intubate every one of these patients? Can we start cooling them and see if their mental status improves? Do we need to protect their airway? And I don't know the answer to that, but I definitely felt the stress of a system that was running out of critical care options. So those are sort of some of my takeaways.
And I'll dovetail on that to say that it's important to remember that you'll certainly see a very large uptick in patients who have heat illness, heat exhaustion, heat stroke, and all the other things. But you'll also see a lot of exacerbations of chronic disease. And then you'll see a very large overlap of patients who are hot, look like they have heat stroke, but they also look like they may be having conventional stroke, and you're going to still have to evaluate them for that while you're also treating their heat illness. And that is an added extra strain on the system. It's an added cognitive load for the providers. The other thing that didn't come up is that these events have tails, meaning that I continued to see patients who had complications related to heat exposure days after the event. And our healthcare system, I think, probably struggled for weeks after the event with additional load that probably was related to that heat exposure. And so when we think about capacity, we really have to think about additional demand, other issues that are already threatening capacity, and then compound hazards, which in many ways compound climatic hazards. This was a compound hazard with COVID, but there are other ongoing chronic stresses on the system as well. And then you throw a wildfire in the mix, or another day of heat, in fact, and power system, distribution challenges, and we would have been in much more trouble than we were in already. So
there's just two other things I'd add on. One, I think Dr. Hess highlighted with COVID, we had a lot of patients who were nervous to go to air-conditioned buildings, like public buildings, like malls and things like that, that previously they said they wouldn't have had an issue going to. And then the other thing, and it's very easy to say it kind of now in hindsight, is we maybe kind of waited a little late to respond. We're a trauma center, and when there's a mass shooting or a natural disaster, I've seen that emergency room empty in minutes. And I think maybe we were a little bit late and kind of behind the times. We didn't realize how bad it would get. It kind of went compounded slowly until it came all at once. So I think in the future, we'll be a little bit better prepared when we hear the 5-day warning for a heat emergency or heat advisory.
you're muted, Cece.
Thanks. Well, thank you all so much. This is fascinating and so many incredible lessons learned. I really appreciate you all being here today and sharing your knowledge and your experience. I think we have so much that we can build upon by sharing these experiences among the health community. I'd like to let you all know about an event we have next week. It's going to be August 31st at 11 a.m. Pacific time. And we'll be doing a similar event looking at wildfires in the West with a panel of experts, and we welcome you to join that. And again, thank you all so much. Thank you for the providers for being there in that crazy situation. And I know that together we can move forward and really start getting a handle on these events to reduce suffering. So thank you all for being here today, and look forward to seeing you again soon.